Hello and good evening, all. I welcome you on behalf of Voice of Healthcare and thank you all for joining in for the panel discussion on Uniting Voices for Colorectal Cancer Awareness, organized by VOH and supported by Merck. March is observed as a National Colorectal Cancer Awareness Month to highlight the importance of screening for colorectal cancer as well as to promote healthy lifestyle habits that can decrease a person's risk of developing colorectal cancer. This series aims to raise awareness and provide comprehensive insights into various facets of colorectal cancer. Through a series of engaging panel discussion, we aim for collective voices of individuals, medical experts, policymakers, and the community to be harnessed to create a more impactful awareness campaign for colorectal cancer. Now, I would like to welcome our esteemed speakers for the day who are the experts in the field of oncology. Dr. P.S. Dattatreya, Director and Chief Medical Oncology Services, Renova Saumya Comprehensive Cancer Care Center, Telangana. Welcome to the panel discussion, sir.
Thank you, madam.
Dr. Linu Abraham Jacob, Professor Head and Department of Medical Oncology, Kidwai, Memorial Institute of Oncology, Bengaluru. Welcome, Dr. Linu.
Thank you.
Professor Dr. Brigadier S.Viswanath, Senior Medical Oncologist, Apollo Cancer Center, Chennai. Welcome, Dr. S.Viswanath.
Evening. Thank you.
Dr. Srinath Bhardwaj R., Consultant Medical Oncology, Apollo Cancer Center, Hyderabad. Welcome, Dr. Srinath Bhardwaj.
Good evening. Thank you for having me here.
Thank you, sir. Now, I would like to express my utmost pleasure and gratitude to be on this platform with the distinguished speaker as the moderator. We have all come together to know that how can the collective voices of individual medical experts, policymaker, and the community be harnessed to create a more impactful awareness campaign for colorectal cancer. Without wasting any more time, I would like to proceed for this panel discussion, and I would request all the doctors present over here to put light on the colorectal cancer awareness. I would like to start by how we can empower the public. I would like to ask the question from Dr. Linu Abraham Jacob that what are the key signs and symptoms of colorectal cancer that the public should be aware of, and how can this knowledge contribute to early detection, and in what ways can the public be empowered to recognize to act upon potential colorectal cancer symptoms?
Thank you. Uh, there are many different signs and symptoms that may point to an underlying colorectal cancer. Some of these symptoms may be caused by other conditions, other common conditions as well. But it is important to know them so that we can have a high index of suspicion. The common signs and symptoms of colorectal cancer include one, change in the bowel habit. That is a change from the normal, maybe in the form of constipation, diarrhea, or alternating constipation and diarrhea, narrowing of the stool. Two, bleeding per rectum, or rectal bleeding before or after passing motion. Third, blood in the stool, so that the stool becomes dark brown or black and sticky. Four, feeling of incomplete evacuation, that is the urge to pass the motion again even after having passed. Fifth, pain in either in the stomach or in the abdomen or belly. Sixth, unexplained or unintentional weight loss. And sixth, tiredness or generalized weakness or fatigue, and this may be as a result of the chronic bleeding from the tumor leading to anemia. So in case of any of these symptoms, it is imperative that the doctor is consulted and advice sought. The doctor may examine and order additional tests to find out the root cause of the symptoms. And if colorectal cancer is suspected, it is what is usually done as a colonoscopy. So it is important that you have a high index of suspicion and not to come to any conclusion yourselves. If colorectal cancer is detected early, it is completely curable. For that matter, for any cancer which is diagnosed in the early stages, it can be completely cured. But if you neglect the symptoms and the cancer becomes advanced, then the chance of cure is lost. Always remember that anybody can get cancer. So, irrespective of your caste, creed, religion, region, financial status, anybody can have cancer, and nobody is immune to developing cancer. So, just because you do not have any unhealthy habits or addictions, or you lead a healthy lifestyle, that doesn't make you immune to developing colorectal cancer. So if any of these symptoms are there, it is important that you give its due importance and seek medical help.
Thank you, Dr. Jacob, for putting light on how what are the signs and symptoms of colorectal cancer. But yes, you said it right that no one is immune to cancer. Anyone with a healthy lifestyle or a non-healthy lifestyle can develop cancer, colorectal cancer. But if I have to talk about the risk factors and prevention of colorectal cancer, I would like to know this from Dr. P.S. Dattatreya. That could you please elaborate on the major risk factors associated with colorectal cancer, and how can an individual modify their lifestyle to reduce these risks? And how can community-based initiatives play a role in preventing colorectal cancer? And what role do policymakers have in the supporting these initiatives? So you are on mute.
Is it okay now? Yeah.
Yes, sir.
Very, very nice question, madam. I think it's pertinent for each of us to understand that we talk about, on one hand, causes, on the other hand, risk factors. So, for instance, we all know that tobacco smoke or tobacco chewing is a very important cause of head and neck cancer or lung cancer. But usually, in some cancers, you don't really have a cause which you can pinpoint to that this is the cause for that particular disease. But we can have some risk factors. And we, through various data and statistics and various studies, do come to a conclusion about what the risk factors can be, which can predispose a person to get colon cancer. For breast cancer, too, you'll talk about risk factors for breast cancers. For colon cancer, the risk factors are having a precancerous condition like colonic polyps or colonic adenomas. So colon cancer doesn't develop overnight. Usually some precancerous conditions found on a colonoscopy can identify these colonic polyps, which are called as adenomas. And over a period of years, adenomas get converted to carcinoma. So colonic polyps or colonic adenomas, risk factor for colon cancer. Some colonic inflammatory diseases like Crohn's disease, ulcerative colitis also are risk factors for getting colon cancer. Colon cancer, by and large, develops in men and women around the age of 65 years. The average age is around 65 years or 62 to 69 years. So the older the age, then that becomes a risk of a colon cancer. Having said that, younger adults too can get colon cancer, but usually it's a disease of older age. Obesity, sedentary lifestyle is also a risk factor for colon cancer. We are what we eat. I think we all know we are what we eat, and therefore, a diet which is low in fiber and high in fat, or these westernized diets, are also an important risk factor for getting colonic cancer. Low fiber and high fat diet. There are some syndromes like Lynch syndromes, where you don't have polyps and still these patients are predisposed to get colon cancer because there's something wrong in the genes or something faulty in the genes. So this Lynch syndrome and other conditions like Lynch syndrome can also predispose to colonic cancer. There are other inherited conditions too, which can be a risk factor for getting colon cancer. They account for 5 to 10% of all colon cancers. Don't forget that other family members, especially first degree relatives, if they have this family history of colonic cancer, like in the parents or the siblings or the children, then you need to be extra alert because that places you at a higher risk of getting colon cancer. Some non communicable habits, like for example, smoker studies have shown that tobacco smoking, be it active or passive, could be a risk factor for colonic cancer. And similarly, recent studies have shown that non communicable disease like type 2 diabetes patients, especially if not well controlled, can be a trigger or could be a risk factor for colon cancer. So, to cut the long story short, knowledge is power, and therefore, let me empower the audience by looking out for these risk factors. To summarize, remember colon. So C standing for colonic polyps and colonic diseases, O standing for older age and obesity, L standing for low fiber, high fat diet and Lynch syndrome, O standing for other inherited conditions and other family members, don't forget the history, and lastly, and standing for non-communicable habits like smoking and non-communicable disease like type 2 diabetes. Now, having said that, since we are now with the knowledge empowered about understanding what the risk factors of colon cancer are, one important question I need to also address is how can we lower the chances of getting a colon cancer or rectal cancer? For that, screening already was addressed to by my previous esteemed colleague. In addition to that, I think screening will be discussed in length by other speakers too. Screening for colon cancer means identifying the disease even before there are some signs and symptoms. So, screening for colon cancer is an important way to prevent colon cancer. Either the disease or identify it in a precancerous condition before colon cancer is developed. Use of certain drugs like low dose aspirin in a dose of 70 for 81 mg per day is thought to protect against colon cancer. Managing body weight is also one more way. Please try to have the ideal body weight for your height. So, managing body weight, preventing obesity, having a healthy lifestyle, being physically active goes a long way in preventing colon cancer. And lastly, managing your food choices. And that's why I said we are what we eat. So my two bottom lines become knowledge is power, and number two, we are what we eat. And these two can go a long way in preventing colon cancer. And for that, all of us need to collaborate. Government policies have to be made so that these risk factors are to the public communicated regularly at regular time choices, and screening should become a part of the national cancer prevention program. I hope I was able to answer all the three sections. Thank you so much for making me a part of this august gathering of esteemed panelists.
Yes, sir, you expressed it very well, all the risk factors and preventions of colorectal cancer, and you said it right. We we are what we eat, and exactly it shows through our health if we are having unhealthy diet, not proper food, unhygienic food. It will reflect in our health, and that's how we should be empowered by the knowledge of what should we eat, how should we lead a healthy lifestyle, so that we can avoid all these complicated diseases in our life. And that's why we all are gathered here to create awareness on one of the dangerous disease that is colorectal cancer. Thank you so much, sir.
Thank
You
you.
explained it very well. And I would like to move forward on how we can do the screening and diagnostics measures. So I would like to ask from Dr. S. Viswanath, like what are the various screening methods available for colorectal cancer, and how these be made more accessible to a wider population, and How can educational program increase awareness about the importance of regular screening, and what role can healthcare provider play in promoting healthcare adherence, screening adherence?
As far as colorectal cancer is concerned, screening is very important. Why? What is the importance of the screening? The incidence of this colorectal cancer, although all over worldwide it is slightly decreasing, but still it is one of the higher ones. In fact, if you go to the Western world, especially here, it is third among the men and fourth among the female. As far as India is concerned, it is in the top 10 important cancers which cause increased mortality and also increased incidence. Now, keeping that in view, that means with the large population which we are having, the importance of screening is that by doing a screening, we can bring down the cost on the healthcare result. Because treating a colorectal cancer is more costly when compared to early detection. So that is the importance of screening as far as colorectal cancers are concerned. And another important concern as far as colorectal cancer is concerned is that our dietary habit in our country is also slowly leaning towards the Western habit, and gradually we may have further increase in the incidence of colorectal cancers. Not only that, if you see the age profile of the patients who are getting this colorectal cancer, previously, as our speakers have clearly told, it was 65. Now, since 2009, there is a slight increase in the age group, especially among those between 45 and 50, and it's gradually increasing at the rate of around 1% per year. So this is a very active group of people in the society who will be more productive to their family and also to the country. And if this chunk of population are involved in colorectal cancer and suffer due to that, then there's a loss of money to the extent. Coming to the screening programs, as far as any other disease is concerned, non-malignant disease, we try to use screening program to detect a case before it appears. But in malignancies, generally, two aspects in screening we have. One is to find out asymptomatic cases. Second, to detect, thereby detecting early stages. Treating an early stage is very, very easy when compared to treating an advanced stage. Now, when we come to this screening program, generally what all over the world we follow is the United States Prevention Services Task Force recommendations. If you see these recommendations are the type of tests which you want to do on these patients. One is what we call a structural test. For people to just understand simply, in the structural test, we actually try to see what is there inside the food. And the main way by which we see that is colonoscopy or sigmoidoscopy, or nowadays we have the CT colonoscopy where we don't put any invasive tubes. With the CT scan, we are able to screen. I'll later come in detail about these things. Then the non-structural is that one we see for because generally, as our already esteemed speakers have already told, there will be the bleeding and other thing passing of blood in colon cancer. You can check whether the patient is having any bleed. If the patient is having obvious bleed, yes, the patient is going to tell you, come to you with symptoms. So we see for what is known as occult bleed. That means the bleeding is not seen to the naked eye. So we try to pick up those cases and try to investigate further. In this itself, there are various types of tests. You have one is the fecal occult blood testing, another one is high sensitivity fecal occult blood testing, and is the multi-targeted stool DNA testing which we do. The importance of this thing is that it is slowly coming up, and as far as the Western countries is concerned, most of them are following it. In India, we yet to start a proper screening program itself, mainly because the vastness of the country. Second, we have to educate. Now, because some people are very skeptical about putting a scope inside, certain blood tests are coming to test blood biomarkers. Those are also coming up, and they are all FDA approved also. In Western countries, they are using it. Now, when we come to screening, we broadly divide the population in average risk and high risk. But there's a slight, when we think about average risk, there's a slight change. One is absolute average risk. All we don't call it low risk, we call it average risk. Then there's the high risk, then increased risk, and there is high risk. Now, this average risk is all the people above 45 years of age is this colonoscopy or any of one of these tests are recommended. If when we any of all these people who don't have any other predisposition or risk factors, which we have already described before. When none of these are met, then they are considered as high, average risk people. When after doing a colonoscopy, when you come to know that the patient is having a polyp or various types of growth inside the tumor or inside the colon, but they do not have cancer, or these tumors have a high propensity to turn into cancer, those are called, categorized as increased risk. And the high risk are those genetic category patients have a genetic predisposition for developing cancer. Those comes under high risk category. When we take into consideration this average risk, colonoscopy is one of the best recommended. This one full length, what we call full length colonoscopy, which sees up to colon, where the small intestine joins the large intestine. Till that place we are able to see. That is the best. And in an average risk, this is advised once in 10 years. We need not do it very high, once in 10 years. When we come to other tests like sigmoidoscopy, this sigmoidoscopy is this one where we are able to see only the descending colon, to some part of descending colon. Why this is? Because all these tests we have shown that the descending colon pickup, that is the distal colon, there the incidence of pickup and prevention is quite high when compared to proximal, that is the further, which is in the front, what we call as ascending colon. When that is the case, so sigmoidoscopy is also one of the recommended, and this has been tested by various trials, and we recommend sigmoidoscopy once in 5 years. Or if the patient is not ready for any of these invasive procedure, we can ask him to undergo this one, CT colonoscopy, and again this is recommended once in 5 years. Now this is when we are doing these things, these tests are only enough. There is no other additional test required. Suppose if you are not able to do any of these functional structural tests, then we go for all those other alternatives, that is indirect tests like stool occult blood, which is done once a year, or this high intensity stool occult blood again once a year. Then this multi-targeted stool DNA, which is once in 3 years. But when after doing this colonoscopy, when we place the patient in an increased risk category, at that time the frequency of doing the test changes. It depends upon the type of high risk, whether the patient is having adenomas, or we call what we call as sessile lesions. In those cases, the repetition should be done after 3 months, after the polypectomy or after 3 years. If after 3 years there is no repeat, repeat it after 5 years, and again after 5 years if there is no repeat, then you go back to the averages, do it like average. In case of high risk, depending upon the lesion, like if it is Lynch syndrome, what we have been calling, in there it is recommended that we do it every year. In another condition called as FAP and other condition also, we recommend doing it every year, at least alternate years in these patients. And those patients who have already had colonic cancer, who have undergone treatment, there after the first colonoscopy, which was done, which would have been usually done before the surgery, repeat the colonoscopy after 1 year of the last colonoscopy. If nothing is there, repeat it at least twice a year. And in about 5 years follow-up, if you don't have any repetition, then you can gradually increase the time between further colonoscopies. This is in brief about the screening program. But one thing which is needed to be understood is, we can tell all those things in a very nice way in any panel discussion. But on ground, who is going to implement it? That's the main thing. Only every person, all healthcare providers should be advised that whenever the patient has a rectal bleed or pain abdomen, which does not subside within a week or two, it needs to be addressed seriously. And most of the time, what happens when there is a rectal bleed, it is taken that it is a hemorrhoid or a fissure, and they just neglect it. So this negligence should not be there, because earlier we catch, which is easier to treat, and it is cheaper to treat also. In a big country like ours, because I have worked both in a government sector as well as now I am working in a private sector, I know how much is the cost involved to the government. I've been in government sector for almost 30 years. So this screening is very, very important. What I suggest is, instead of doing the functional screening, which is difficult in all places in remote areas, we should at least standardize our stool occult blood testing, because it has shown There are certain Australian studies, there's a Norwegian study. Every country has difficulty in screening for colorectal cancer, especially those structural screening. But at least this tool, occult blood, this test, if they do, if any patient, any population undergoes any form of screening, there is a reduction in the death due to this colonic malignancy by 36 to 44%, depending upon the type. So any test will give some benefit. So depending upon the this one data which we are collecting from our country, we have to decide which would be the best test to be done at the government level and at the various sectors, because certain sectors will be able to sponsor higher level of testing. So these things needs to be sat and we have to decide on that. Okay.
That's great, sir. You have explained all the screenings and diagnostics measures very well to us, and you said it right. It is very easy to explain all of these on a panel discussion, but when it comes to ground implementing, the gap is there. But the government is still working, and the cost for that is huge. Like you said, you have worked in government and private sector both, and you know the cost involved in that. And it actually that is why we are working on a bit of our job, our responsibility through this panel discussion so that we can explain the awareness of colorectal cancer, and slowly and gradually people will get to know more about it, the knowledge will spread, and the awareness will be there in the society.
In fact, our country was having more of incidence of infectious diseases, so more work was being done on that. With the control of infectious diseases, this lifestyle diseases have started coming up. So we
So
need to look into those things also.
correct, sir. Said it right. I would like to know the same from Dr. Srinath Bhardwaj. Sir, what do you think? What are the various screening methods according to you available for cancer, and how can these be made more accessible to wider population? What are your thoughts on that? And the educational program, how can that increase the awareness about the importance of regular screening?
So, hi, after Dr. Vishwanath has spoken so elaborately about everything, except for maybe a reiteration or maybe summarizing things, I have nothing actually left to really tell anything new. Sir has extensively covered all the modalities which are available. So, so the guidelines say that average risk individual, the age of starting screening is 45. So there's again conflict in the data whether we have to start screening at 50 versus 45. That I think the oncologists in India have to sit and decide according to the incidence of colorectal cancer in our community, rather than following the West guidelines. That is one thing I would like to make my point in that. Two, it's easier to do stool-based tests compared to the colonoscopies. Uh, in the wider population. So, as Sir rightly pointed out, any modality of screening would really, get the incidence down. So, there are various government schemes in India which help patients get their treatments like surgeries and chemotherapies. But if these schemes can be extended to involving a basic screening test like detecting occult blood or hidden blood in your stool, so that's quite implementable widely in the society. Then only we can choose people whom to do a colonoscopy and spend on them. So I think step-by-step approach and putting one test before the other, and then building it and slowly percolating it into the society is what is the need of the hour. So, Sir has very well put forth all the structural and non-structural tests. I'm not going into all of them. Of course, again, our other panelists also have clearly reiterated people with symptoms. So again, symptoms once they are out, I think we have crossed the level of screening. So screening essentially means testing normal population without symptoms. So one, we have raised awareness about what are the common symptoms. Two, we have raised awareness in the second talk about what are the risk factors, what the public have to keep in mind and contact their oncologist. Three, once a colon cancer has been detected in one's family, so the what is the chance of us getting a cancer based on that? That depends on the relationship of us with that particular person. So the near the person, say first degree relative, we call. So our parents, our children are our first degree relatives. So when you have a first degree relative, your chance of getting cancer is much more. So we advise them to follow regular screening that is being already done in the tertiary care level. So again, when people have certain predisposing diseases, like Dr. Dattatreya has clearly pointed out, saying Crohn's disease or ulcerative colitis, inflammatory bowel disease, cystic fibrosis, and personal history of any cancer. So somebody has gotten over a particular cancer and they're under a regular screen. So all these patients automatically are being kind of followed up at the tertiary level. So I think that's not a problem. But here, I think we have structural and non-structural tests, I think, which have to be done in a stepwise fashion in the general society, so that, and the screening tests have to be incorporated in these government schemes. Like there are various state-based schemes. There is a central scheme, Ayushman Bharat, by the Prime Minister. So if they include screening and take a stepwise approach, taking into confidence all the oncology community, I think the amount to be spent on treatment will definitely reduce. So I think that is what we have to alert the policymakers through sessions like this. At the same time, we're educating public about getting themselves screened above the age of 45 and 50. And of course, the key point with the screen, despite all this, is it has been time and again proven that Indian diet is the best diet, and we should stop westernizing our diet and stick to our ancestral basics. So uh, that's what I read out of the entire screening program. I think that has to be the screening program has to be taken seriously by the government and implemented in a way to really cut down on their expenses on treatment.
Yes, so you said it right. The Indian diet is already proven to be one of the best diet, and we should move to that or shift to that as soon as possible. Uh, because if whatever little bit I know from my grandparents and the elders from my family, they never used to have such kind of problems, or much of all these incidents and cases, or even if the detection was very less. So yes, the ancient lifestyle is always better, and we are moving to westernization, and then we are getting more of those kinds of illnesses and diseases.
And
But
being
when it
physically
comes,
active, sorry to interrupt you, and being physically active, I think our ancestors were very physically active, so they were able to also digest the diet. Here, I think the physical activity has come down. Life is very comfortable now. So I think this body is meant to be physically active. It's not meant to be sedentary.
even if our ancestors used to have ghee and makhan and all everything that used to get digested because of the kind of activity they used to perform in their daily life, that was more of physical rather than sitting and doing it that job. So now it is very difficult even for I doctor, you guys are doctors and you can let me know that better, for doctors to digest that ghee or makhan, because there's more of sitting job and less of physical activity, so it becomes very difficult to digest that heavy ghee makhan.
So ghee makan is still better. Non-veg is even difficult.
So, so, so
Ghee makan is still better.
like we talked about the screening and diagnostics measures, I would like to know the same from Dr. Srinath Bhardwaj, the treatment options available and support. Can we discuss the range of treatment options available for colorectal cancer? And how can we know that the cancer is a very dangerous disease? And when a patient is diagnosed with that, then how can patients and their family be supported throughout the treatment journey? In what ways can community foster a supportive environment for individuals affected by colorectal cancer, and what role do policymakers play in ensuring access to quality care?
The question is to me.
Yes, sir, Dr. Yes, Dr. Bhardwaj.
Okay. So there are three modalities which we use to treat colorectal cancers. One is surgery initially, and then came up chemotherapy and radiation therapy. Radiation therapy, we use it only in select locations in the colon. We don't use it throughout the colon. So as rightly pointed out, once the screening program is in place, we tend to detect more cancers which are early, and hence they stand a chance of getting cured just with surgery. So in the initial stages, we don't need any therapy like a chemotherapy or maybe radiation to really prevent a reoccurrence. So that's the exact point we have to emphasize. We've been emphasizing to the general public as well as the policymakers that when you detect it early, the cost of therapy obviously goes down because you're using only one modality instead of two or three. So early stage one, stage twos, most of them might not need any therapy to prevent a recurrence. The second, once it becomes a bit advanced, we'll have to add on chemotherapy. Uh, Sometimes we have to use radiation first before surgery and all that stuff. So obviously the cost of treatment is going up there. So again, emphasizing a point that screening has to be in the government schemes so that we can prevent expenditure on that. uh, I mean, in India, most of the times it's very difficult to find a case in early stages. Most of them ignore their symptoms, maybe due to lack of awareness of the symptoms, and come back to us in stage four. So, stage four means that the tumor has spread out of the colon into the other organs like liver, lungs, bones, and other structures, where now it's virtually incurable, and the surgery is totally out of picture. And there come a lot of other therapies like targeted therapies, immunotherapies, which are even costlier than the actual surgery itself. So most of the government schemes right now are not even covering those latest therapies like immunotherapies and targeted therapies. So even if they have to cover, again the cost is going to be a bomb, and it's more costlier than doing surgery and chemotherapy together. So again, it even more emphasizes that we have a strict screening program in place. So that if not for all these cases, but at least we can cut down on majority of the cases getting or going into an advanced stage. So yeah, these three are the primary modalities. As I told, to summarize, we use surgery, chemotherapy, and radiotherapy in the initial stages, and we use targeted therapies and immunotherapies. They can be in the form of tablets or injections. That's where we use. The other question you told us is you asked is how do you kind of support the families and the patients? I think sitting like this and talking to them is the only way. We will have to. I think one thing which always worked for me is being honest. So you can't sugarcoat anything. You just have to be honest and tell them that this is this, and that's how you kind of comfort or prepare the family for what is eventually going to happen. Because telling nice things and sugarcoating doesn't work here. So I think being honest is the best way to support families. That has worked for me.
I agree to the point, sir. Doctors have to tell the truth and facts so that the family is not in a kind of dark space, and like the patient has to be honest with the doctor. Similarly, the doctor has always to be honest with their patients and the family, with the process and things. Dr. Linu, I would like to know the same from your side, your opinion on, can you please let us know the range of treatments options available for colorectal cancer, and most importantly, how can patients and their families be supported throughout the treatment journey? You always deal such kind of cases in your life, and the responses you get and how difficult it is to actually handle those things in reality, and in what ways the community is fostering a supportive environment for individuals affected by colorectal cancer, and how can a policy makers ensure the access to quality care?
Yeah, I think already it has been told by Dr. Srinath. Maybe I would probably expand a little bit. It's important to tell the truth, but at the same time, I feel that there is a need for a reassurance as well. So I think I would like to start by telling that diagnosis of in the unfortunate event of diagnosis of colorectal cancer, it should not be considered as a death sentence or the end of the road, because with better understanding of the disease and advancements in the treatment techniques, the outcomes are better. The outcomes are improving. The other most important thing is that the treatment should be by a
So your video is stuck. Dr. Linu, your video is stuck. You just wait for a minute uh, if everything goes well. So,
You want me to
Dr.
pitch in
Linu?
the meanwhile so that we don't lose time? I think till Sir joins back.
Yes, yes.
So Sir was talking about having multidisciplinary tumor boards and say where for every case the surgeon, the radiation oncologist and medical oncologist sit together and prepare a comprehensive plan of management. At the same time, assure the patient, of course being honest is important, but also assuring the patient that it's not a death sentence and there are treatments and there are advances happening is what Dr. Linu sir was alluding to. And coming to the therapies, as we discussed, nowadays it's not just the scans, it's not just the say the tissue tests or the biopsy tests, but we've gone to a level where we are analyzing tumor DNA. So it's not that colon cancer is not a single entity and every tumor is different. So we are going into an era where it is personalized treatment. So Sir is back. I think he'll elaborate more on that.
Yeah, sorry, I got logged out. What I was telling was that the treatment should be by a multidisciplinary team of caregivers, not only doctors, not only surgeons, radiation oncologists, or medical oncologists, but also a good group of supportive care persons. So that is important. And as far as the treatment is concerned, I think already it has been told. And once we make a diagnosis of cancer, the next step, what we do is staging. We do certain investigations to find out the stage of the cancer, and the treatment is dependent on the stage of the cancer. So usually there are 4 stages: stage 1, stage 2, stage 3, and stage 4. Stage 1 colorectal cancer is a cancer which is limited to the inner layers of the colon. Stage 2 is once it penetrates through the entire thickness of the colon. Stage 3 is once it has spread into the nearby lymph nodes, and stage 4 is a situation where the disease has spread to multiple organs, distant organs. The initial stages 1, 2, and 3, the intent of our treatment is cure. So we would like to completely eliminate the tumor and give ultimate cure to the patient. And the mainstay of treatment in these early stages, that is stages 1, 2, and 3, is surgery. And following surgery, to prevent the recurrence of the disease, we may additionally add chemotherapy or radiation. So chemotherapy is primarily added to prevent the recurrence of the disease at distant sites, whereas radiation is usually given, especially in rectal cancers, to prevent the recurrence of the disease at the initial site of disease. And with this multimodality management, nowadays we are able to cure up to 90% of the stage 1 colorectal cancers, up to around 80 to 85% of the stage 2 colorectal cancers, maybe around 65% of the stage 3 colorectal cancers. And once the disease is spread to multiple distant organs, the scenario where you have a stage 4 disease, cure is not achievable. In such scenarios, our intent of treatment is palliation, meaning to palliate the symptoms, to relieve the patient of the symptoms, and to prolong life while maintaining a good quality of life. And that is usually achieved by subjecting the patient to systemic treatments, which was already elaborated by the previous distinguished speaker. That is by usually giving chemotherapy, targeted treatment, or immunotherapy. In selected stage 4 cancers, when there is only limited spread of the disease, for example, something called as a liver limited disease, sometimes we may go with a curative intent with aggressive surgery and chemotherapy, and we may reach or we may obtain success or cure in up to 50% of the patients. As far as the second part of the question is concerned, it's very important that friends, the family members, patient support groups all have a great role to play while the patient is undergoing treatment by fostering a supportive environment, by providing physical, emotional, psychological, moral support to the patient during the entire course of treatment. And maybe going to the third part of the treatment, like what the policymakers can do, probably they can set up more cancer centers, ensure availability of expert doctors and caregivers at those centers, probably making available the required equipments, technologies at affordable prices, and even making the latest medicines also at affordable prices would be the main expectations from the policymakers.
Thank you, sir. You covered all the part of the question and you said it right, being honest and giving that assurance, and how well you explained all the stages and the targeted therapy which we can give to the patient, as explained very well. Thank you for that. But if we have to move from the screening, diagnostics, and measures, if we have to go for the lifestyle and diet, like how can we actually prevent and how can we lead a healthy lifestyle without without getting cancer or any kind of illness? Like, I would like to know this from Dr. S. Vishwanath, that how does lifestyle, including factors like diet, physical activity, contribute to colorectal cancer risk, and what strategies can be employed to promote healthier habits in community? What initiatives or educational campaigns can be implemented to inform the public about the connection between lifestyle choices and colorectal cancer?
Yeah, this is a very, very important question which everybody has to understand properly. Now, the thing is, whenever any disease for that matter, when we discuss about the risk factors, especially we used to discuss this even in cardiovascular disease, certain risk factors are modifiable. Certain risk factors cannot be modified. And if you see, as far as colorectal cancer is concerned, most of the people have modifiable risk factors. It's only up to 5 to 10% of the patient, maximum 5% of the patient who have genetic causes which cannot be modified. Age cannot be modified. The race or ethnicity cannot be modified. If you take that chunk, maximum it won't cross 80% of the total world population. As far as the rest of 80% of the population is concerned, it is mainly the modifiable. One, as our eminent speakers have already told, one is the diet. We are slowly changing over to westernized diet. And actually, I want to introspect, is this the only thing? Because even Western people have been using this diet for quite some time. Even there, the incidence of cancer is that age. And even in our country also, almost the age of colon cancer is almost similar to that. Now it is slightly earlier. So is it only the diet, or have we got a fair win over the communicable diseases so that our longevity has increased? So we are seeing more of cancer, or is it because we have more better facilities, accessibility to treatment where it is more diagnosed? So this is one difference. So one is the diet. Second is cigarette smoking. All of us have been thinking that cigarette smoking causes lung cancer, head and neck cancer in public. As oncologists, we all know that cigarette smoking not only causes this one, but it can also cause pancreatic cancer, colon cancer, bladder cancer, various types of cancers it can cause. So one of the cause for risk factors for colonic malignancy is smoking. Another one added to that is drinking. In fact, it is well-known fact that a moderate drinker and a heavy drinker have almost 1.5 to 2 times more chance of getting these colonic malignancies. When we divide this, light drinkers, moderate drinkers, and heavy drinkers, they are going to have at least more than 4 packs per day, at least. Then they are categorized as heavy drinkers. That is, as far as the alcohol content is concerned. This is because we have to have some sort of a yardstick. We cannot just tell 2 packs, 3 packs. Then they will tell whether it is a normal peg or Patiala peg. So it depends. So we have to know that. So when we have to have a clear-cut yardstick, if it is more than 50 ml of alcohol per day, then the risk almost doubles. If the amount of alcohol which we take is between 12.5 to 25, then the chance around 1.5 times. This is a rough idea. So this shows that alcohol, although we may think that it does not have, it may cause only liver involvement, liver disease, it does have an effect on all the malignancies also. Next is your body mass index, what we call. When we so we have to maintain a correct, for our weight, the optimal weight needs to be maintained, because increased adiposity can increase the incidence of colonic malignancy, and not only that, it's more, any malignancy can increase, but more so in colonic malignancy. This is mainly because a patient having more fat in the body tends to have what we call as chronic inflammation. That is, we all see inflammatory reactions. That is, patient having pain, swelling, and redness in any of the injured areas. Suppose you get a hurt trauma somewhere, we see this finding. But if the patient is fat, then there is a chronic low-grade inflammation, which causes various types of gives attributes to various types of malignancy. So bringing down the body fat is very important. These are some of the modifiable factors which we can easily modify, and it is within our control. And 80%, that is major chunk of the population, fall into it. So with this control, our incidence can come down significantly, incidence of colonic malignancy. Other than that, age and ethnicity, fortunately in our country, we don't have much of ethnic variation. So we can have a more or less a uniform guideline for that. Then genetic predisposition is hardly 5% of the total population of colorectal malignancies. So based for this, when we adopt the screening programs according to their risk factors, suitable to their risk factor, we can bring down the incidence of colonic malignancies quite significantly. Other than this, when we are talking about how the government can implement many of these factors, see, we cannot expect that our government can do colonoscopy for most of our population who are more than 45 years of age. It is next to impossible. Even in the most advanced countries, they are not doing it. In fact, I wanted to say, when compared to Western countries, certain screening programs are much better here in our country. So this fecal occult blood testing can be done at many of our periphery centers. But the problem with fecal occult blood testing is the doctor or the healthcare provider needs to be trained in that regularly with refresher courses. Because it is not that they take the blood and just do it. They have to be very clear cut when to do it, what should be the preceding what diet to be prescribed to the patient before doing the fecal occult blood testing. These are all very important, and it is not rocket science. We can always teach them, and definitely so, depending upon various level of their acceptability, we have to reiterate, keep telling it. We have to have regular refresher courses in this thing for all the healthcare providers, right from taking the sample up to transportation to the lab and the testing in the lab. These needs to be trained and refreshed regularly. And not only that, when we start a screening program, today you are starting the screening program, don't expect a result within 2 days. We need to continue this screening program at least for 10 years to show some sort of a change in the incidence and death rate. You cannot expect it overnight. So when we are planning the cost, financial effects to this, we have to factor in that this needs to be carried out like a different 5-year plan. So the budgeting should be done accordingly, extending up to 10 years. That is very important. Third, whenever you see the pharmacoeconomics of treatment of any of the patient, the cost factor of treatment as such is around 45 to 50%. The remaining 50% is the transportation charges. And because whenever there's a cancer patient, there's always 1 or 2 people accompanying to take care of him. And none of these cancer centers are really so closely accessible. So they have to travel the travel cost, the stay cost, food cost, these all needs to be factored into. So whenever we are able to factor these costs and help people, then it will become quite a successful decision. So we need elaborate discussion into this. We have to foresee when we can expect results. Overnight we cannot. Even 2 or 3 years of follow-up also will not give us result. At least a program which has to be run for at least 10 years. Then only we will be able to fetch a result. Why I am telling this 10 years is there's slight scientific data for that, because for a malignancy from a polyp to become a cancer, it takes 10 to 12 years. So when you are following up the patient to have new cases from adenoma, which we have already resected during colonoscopy, for him, if he has to develop a malignancy, it will take at least 10 to 12 years. So this 12-year factor, at least we should keep. Ideally, more the number of days. So it should be some sort of a long-term plan which you have to do. So that is one of my suggestions, that it should be a long-term plan of screening in our country. And this one thing is, should be something like a center and spoke. You have a center which is a tertiary care, which has all the facility. Then we have to do it stepwise. The next step, you can have only colonoscopy, and peripheries, you can have this simple blood test. When somebody is detected positive, he is sent to the next level. Further positivity, turn to the tertiary level. So this type of a spoke kind of a picture, if we have, then it may be more economical also.
Thank you so much, sir, for giving us this great insight and explaining this very elaboratively. And you said it right, 10 to 12 years is minimum required to make the screening process successful, because any new launch, any new program which is going to be there established would need some kind of uh, results on field research, and that then only we can implement this and can be successful. As we are a little bit short of time, I would just quickly ask Dr. Dattatreya about how can different sectors, including medical experts, policymakers, and community organizations, collaborate to strengthen colorectal cancer awareness and preventive efforts. Also, what actionable steps can individual and organization take to contribute the ongoing fight against colorectal cancer?
Excellent. So basically, I would also like to sum up what all we have been discussing till now.
Sir, you are on mute.
I'm audible now? Yeah.
Yes, sir.
So essentially, cancer, as we all know, is a six-letter word, and cancel also is six-letter word. We all are here to see if we can cancel cancer, and the focus today is colon cancer because this is the colon cancer awareness month. So let me try to end what all we discussed over the past 45-50 minutes by telling all the audience and the viewers that number one, the C in cancer tells you that cancer is curable if diagnosed early and treated appropriately. And that's what all my eminent colleagues and speakers have been talking about, including screening all the way to treating even stage 4 diseases. But cancer is curable if diagnosed early and if treated appropriately. Number two, the A in cancer would stand for activities to raise awareness. Multiple continuing medical education programs to train our MBBS doctors, family doctors, and the registered medical practitioners so that everyone is aware about this disease, how to diagnose, how to identify, and make sure activities are being done to raise awareness among our colleagues and the medical fraternity. The N in cancer, colon cancer. In fact, cancers by and large are non communicable diseases, they are lifestyle diseases. And so, as I told you before, we are what we eat. And so, a healthy, hygienic, balanced diet will go a long way in making sure we can prevent these diseases. On the other hand, it's also important to know, and as was mentioned by our eminent colleagues, that there are some modifiable causes, there are some non modifiable causes too. But then, this basically is a non-communicable disease, by and large a lifestyle disease. So have a high fiber and a low fat diet, avoid westernized diets, etc. Then the next C is concerted efforts at the level of the community, not just my medical fraternity colleagues like MBBS doctors, RMPs, or my MD physician colleagues, but at the community level, we have to educate the masses. So this has to be a community level education, trying to reach out to the layman and general public also. Then E, as was rightly mentioned by Vishwanath sir, expectations should not be unrealistic. We should have realistic expectations. And so when what happens when the expectations are so high and the outcome is less, the result is less, this gap is frustration. So we need to be patient. And so when you're talking about colon cancer, especially, you need a long time before results will get to be known or shown by the governments and the government programs. So have expectations which are realistic. And lastly, our regularity is very, very important. We need to be regular. This is not a one-time affair. It's not a one-time job. We need to be regular in our fight to defeat cancer, in our battle to beat cancer. It's a crusade to cancel cancer. And this effort today by all five of us is one such effort, concerted to make sure we reach the community and educate the people about cancer is a word. It's not a sentence. A sentence has a full stop. A word doesn't have full stop. So cancer does not mean the end of the world. Cancer is a word, it's not a sentence. Let me end with an African proverb. If you want to go fast, you can go alone. But if you want to go far, you need to go together. We want to go far in this fight against this dread disease, and therefore all of us are united here today to communicate to the public that we are all with you in this fight against cancer. So to go fast, go alone. But if you want to go far, go together. Thank you so much.
Thanks a lot, sir. Said it right. We all are together in this fight. That then only we can go far and beat this cancer. Thanks a lot for taking out the time, and this is the best summarization anyone could have given. Thanks a lot for sharing your time and coming to a platform for raising this awareness together and going far with the vision of going far to fight this colorectal cancer. Thanks a lot for sharing the insights and creating the awareness with Voice of Healthcare supported by Merck. Thank you all.
Thank you,
Thanks a
VOH,
lot.
and
Thank you.
for having all of us here. And it was a great session and great learning for me.
Thanks a lot.
Thank you.
Thank you.
Bye bye, everyone.